Morning, back again with another talk. I shall be discussing my experience and our protocol that we follow when we encounter a patient with febrile illness. Again, I'm a disclosure. Now that we have an obstetric physician in our hospital, most of the patients are initially screened by physician, and then subsequently, if the patient is very sick, they come to us. So basically, we have an obstetric medicine team where obstetric physician, obstetrician, and anesthesiologist, intensivist, we jointly see this patient, especially if the mother is sick, and then jointly evaluate. So when you look at the cause of maternal mortality, courtesy, again, Toxicon and Dr. Paili sir, they have evaluated extensively why mothers die in Kerala, and we know that febrile illness and the maternal mortality, sepsis, septic abortions, respiratory and viral diseases, and jaundice complicating pregnancy have contributed significantly to the maternal mortality. And our own data from Fernandez Hospital, slides are not moving. Sepsis is one of the third common cause of ICU admission in our hospital. So basically, febrile illness can it's worrisome for the clinician. And I thank our obstetric colleague, Dr. Nusrat, for giving me this data. But if you look at the importance of the incidence of near miss and the maternal mortality rate associated with various disease condition, this was the audit that was done almost for 3 years, 28,000 deliveries, almost 29,000 deliveries were assessed. And if you see hepatitis and sepsis, the incidence of near miss is almost 1 in 2.8, 1 in 1, and the mortality also is 1 in 14, very, very high. And sepsis also, the near miss is 1 in 4, and the maternal mortality is 1 in 27. So basically, when you look at disease-specific mortality, febrile illness is one entity that cannot be taken for granted, and how we evaluate, what do you want to evaluate depends on how the patient presents. So any patient who walks into obstetric unit, I recommend strongly that we use universally the modified obstetric early warning chart, which is very, very important. And depending on which system the mother is deteriorating, like we all know, the first parameter is respiration, the pulse rate, the temperature, the CNS, and other things which are there. If you monitor, we can evaluate appropriately so that we don't waste resources or we utilize the resources judiciously. And of course, we all know about the triggers that we have in this modified early warning chart. Again, when you have MUSE in place, like modified obstetric early warning chart in place, it is very important that you have appropriate tools also, because majority of the time when the mother is sick, tachycardia, tachypnea, hypotension, or hypertensive crisis, they are common presentation. And if you look at this thing, any abnormal condition like heart failure, peripartum cardiomyopathy, respiratory failure, acute pulmonary edema, can all present with pulmonary embolism, can all present with tachypnea, tachycardia, hypotension. So which pathway to be activated depends on the obstetric tools that you have, and appropriate pathway can be targeted so that appropriate evaluation can be done. So sepsis pathway is targeted when the mother presents with history of fever. But having said that, a small chunk of HELP syndromes, AFLP, they also have low-grade temperature, febrile flu-like illness that you have to keep in mind. So you need to have appropriate early warning chart, appropriate early warning tool so that you can target appropriate evaluation. So when we discuss about what panel of investigation you want to send, it all depends on the symptoms, whether the patient comes with predominantly urinary symptoms, because we know that pelvic sepsis, either intrauterine sepsis, chorioamnionitis, vaginitis, or urinary tract infection are the commonest cause of febrile illnesses, followed by respiratory infections, acute cholecystitis, appendicitis, or any of those non-obstetric conditions can be involved. So our common thing sometimes we, especially male intensivists, we tend to ignore the breast abscess or any incidents, so if you don't examine the breast. So you need to have appropriate symptoms, chalk out the appropriate organ involvement, and so that we can have a targeted treatment. Again, a simple fever need not need elaborate evaluation, because we know that clinical assessment supersedes laboratory assessment. Very, very important. And not all febrile parachutes are serious, but importantly, unrecognized simple sepsis can be fatal, can kill a mother. So we need to keep that in mind. So whenever we have any patient, at least do the basic workup. The basic workup is CBC with peripheral smear, midstream urine examination, because we know that urinary tract infections are commonest cause of febrile illnesses, and targeted cultures, either midstream urine culture, blood cultures, amniotic fluid culture, if you're suspecting chorioamnionitis or vaginal swab. Vaginal swab to be taken with Cusco spectrum so that you don't get contaminants. And importantly, you're suspecting chorioamnionitis, also send cord blood for blood culture, because we know that vertical transmission also is common, and sometimes you can minimize or avert a neonatal mortality also. Lactates are very, very useful point of care testing tool. So have a low threshold to do blood gases. Need not be always the arterial puncture. You can always take a venous sample and look at the pH and look at the lactate, because we know that if the lactate is more than 1.5 millimoles, you need to be little serious and you can't neglect this patient. Probably this patient needs high dependency care. And just to give an example, this was again a case report I picked up from Why Mothers Die from Dr. Piley's manual audit. One of the cases that caught me was this ERPC, surgical ERPC, simple case, surgical ERPC done under general anesthesia. Patient had intraoperative hypoxic arrest, probably. I don't know how this patient developed hypoxic arrest under anesthesia, because we couldn't find the details. But importantly, patient received the best of resuscitation possible in that setup, and subsequently it was diagnosed to be having surgical ERPC for septic products. And this patient also was given ECMO support, but to no avail. Patient succumbed. The point which I want to emphasize is simple procedure like ERPC, ending up ERPC to ECMO, and patient had a mortality. So basically, sepsis is one illness which cannot be negated. We all know this young dentist in 2013 in the developed nation in Ireland. She succumbed to sepsis just because things were delayed. It was a miscarriage with low-grade fever. Investigations were sent, but were not followed up. Many times we send CBC, and we think that our CBC will be corrected by our colleagues in the next shift, and it doesn't happen until the patient deteriorates, and then it's too late. So basically, this patient again was the case of fatal near miss ending up with a maternal mortality. She gave a window of 72 hours, and nothing happens all of a sudden. So basically, what I want to emphasize is having a modified obstetric early warning chart in your hospital, looking at the trend of vitals is of paramount importance. And when you are sending any investigations, including CBC, just don't look at HB hematocrit, because many a times some of our colleagues, they just look at HB because the patient is dead, but they fail to look at TLCs, total leukocyte count. And when you look at WBC count is 8,000, you are very happy. But look at the differential count, because WBC count, normal count, the number may be normal, but the neutrophilic count may be 92%, 98%. So with the normal TLC, look at the differential count, look at the peripheral smear, look at the shift to left, because when you have premature neutrophils in the bloodstream, it indicates that the neutrophils are the bone marrow is rapidly sending neutrophils, premature neutrophils into the circulation. So look at the peripheral smear, look at the report in toto, the right report of the right patient, before you conclude. It's very, very important. I'll just discuss two cases. This was a patient who came to us unbooked referral, G3P2L2 previous 1 cesarean section, comes into labor, history of PROM of 12 hours duration, no history of fever, TLCs are normal, WBC count, differential count is normal, vaginal swab was sent, and she was, because she was in labor, she was taken up for cesarean section. PAC was unremarkable. It was done under spinal. Plan B was general anesthesia, but luckily it was spinal, was uneventful with a 29 gauge Whittaker needle. Importantly, post-spinal patient developed hypotension, which is common actually. But many times the amount of vasopressor that is needed to treat hypotension is about 6 milligrams of ephedrine or 50 to 100 micrograms of phenylephrine. This patient needed prophylactic, despite prophylactic phenylephrine of 100 micrograms and co-loading, she needed 400 micrograms of phenylephrine to maintain MAP of at least 60-65. And she also needed 30 milligrams of ephedrine. So when you have profound hypotension, unexplained hypotension intraoperatively, think of, activate the algorithm. Is it cardiac? Is it septic? Is it embolism? Intraoperative? We need to know. And when we evaluated, we did a blood gas. We see intraoperative hypotension can be because of spinal anesthesia also, high spinal, total spinal. But in this case, the level was D4, high spinal was ruled out. She was able to phone it well. So anesthetic causes were ruled out. We did an ABG, lactates were high. We sent procalcitonin, recalcitrant was high. We sent blood cultures. We discussed with the neonatologist. They sent the cord blood cultures, and it turned out to be E. coli in all. Mother grew E. coli. the baby grew E. coli, and we stepped up the antibiotic intrapartum, intraoperative period, and patient was discharged on 6 post-op day. The point which I want to emphasize is, just because of high index of suspicion, proactively managed and we could avert a morbidity. In the same patient would have deteriorated, slipped into hypertension after surgery, and things would have worsened and probably would have missed the bus, ended up with the morbidity. This was another case that came to us. She was a diabetic, it came with diabetic ketoacidosis, no fever, TLCs are normal. She was resuscitated adequately. Fair glycemic control was achieved, but despite fair glycemic control at the end of 36 hours, she developed hypotension, required supranormal doses of vasopressors, noradrenaline, adrenaline, and vasopressin also was given. The skin became mottled, and despite double dose of vasopressors and hydrocortisone, the pressures were low. We just terminated the pregnancy, and basically she was found to have a breast abscess also, and we just drained the abscess, terminated the pregnancy, drained the abscess, and there was rapid improvement. So what this mother needed was proper source control of breast abscess, and termination of pregnancy was needed. So basically, sending cultures is of paramount importance, analyzing report is of paramount importance, and when you have bugs, escalate the antibiotic. We'll discuss more on this in the panel discussion, but importantly, cultures and procalcitonin, biomarkers are very important. So whenever you have patients with febrile illness, complete blood picture with peripheral smear, look at the complete report, just don't look at mere HB or platelets, just look at the complete platelet report. LFTs, LDH, urea creatinine electrolytes, very, very important, because we know that AFLP HELP syndrome also can cause deranged LFTs and LDH, but whether it is an obstetric cause or non-obstetric cause, we need to delineate, and it will come with experience and wisdom. But importantly, dysregulatemia is common, oliguria is common, creatinine gets elevated, and we know that this patient may need hydration, targeted volume assessment, and targeted cultures, very, very important. Have a low threshold to send lactate, and when you repeat these investigations, if anything is deranged, trend it. Again, repeat at the end of 6 hours, 12 hours, especially blood gases, so that we don't miss out the bus. Importantly, if the mother is sick and cultures are negative, or you are waiting for cultures, nowadays we have this multiplex PCR, very, very useful. The biomarkers, CRP, procalcitonin, they just indicate there is some inflammation, infection ongoing, but we don't pick up the right type of infection. So multiplex PCR like BioFire panel that we have currently available in most all the cities, I'm sure we have in Thrissur also. Basically, it diagnoses bacteria, fungus, and viruses. Just any of the secretions, like you can send sputum, you can send pleural, any of those fluids, you send this multiplex PCR, and the sensitivity is almost 98%. And if you have negative BioFire panel, virtually you can rule out infection. It could be non-infectious cause of inflammation like pancreatitis or any of those other pathology. And we have this availability of MALDI-TOF also, basically nothing but matrix assisted laser deabsorption ionization. Basically, it's a mass spectrometric method to evaluate the culture positivity early. Within 6 hours, you know what bug you are growing. Even otherwise, the routine culture bottle, the bacteric bottles that we have in our hospital, if you send the aerobic culture, you can pick up within 6 to 8 hours. And anaerobic cultures, they take about 24 to 36 hours. But gram-positive growth, you can pick up within 15 to 17 hours. Gram-negative growth, you can pick up within 8 to 12 hours. So if you have a closed-loop communication with a microbiologist, suspecting sepsis, at least you know if it's a gram-negative growth, it could common, it could be Klebsiella, Pseudomonas, any of those things, you can give targeted therapies. Very, very important. So biomarkers are very important, CRP, procalcitonin, and if the patient's malignancy, complicating pregnancy, or any of those immunocompromised patient, you can send fungal biomarkers like galactomannan or 1,3-beta-glucan. Like it indicates, galactomannan indicates aspergillosis, 1,3-beta-glucan indicates invasive candidiasis. Very, very rare. I still remember we had one case of invasive mucormycosis causing multiple GI perforation in a pregnant patient. Very rare. That was only invasive fungal cancer I've seen in the last 27 years. So you just have to remember that biomarkers are available. They can guide the clinician, and appropriate targeted therapy can be started. So multiplex PCR, have a low threshold to send multiplex PCR, and importantly, MALDI-TOF also is quite helpful. The major limitation of multiplex PCR is it can sometimes identify non-pathogenic organism also. But when the patient is symptomatic, when the PCR is positive, give a targeted approach, and cultures anyway are going to come within the next 24 to 48 hours, and you can de-escalate the therapy. So whenever you have any febrile illness, it could be viral, it could be bacterial, and very, very rarely fungal. Targeted therapy, targeted approach is very important, and to avoid a morbidity. Again, I would say panels have to be sent as per the symptoms. So if the patient has epigastric pain, non-infective causes like lipase, MRS, acute pancreatitis, complete pregnancy as we discussed earlier, or lung ultrasound, chest X-ray, if the patient has fulminant respiratory failure and requiring HFNC or non-invasive ventilation, invasive ventilation, then have a low threshold to do HRCT also. Because again, HRCT, if you look at the safety exposure, you can put a lead shield, and risk versus benefit, it is always benefit always supersedes the risk. And if the mother has altered sensorium with fever, you need to suspect meningitis or CSVT also. So MRI with MR venogram of brain can be done, can be targeted. And see a post-operative altered sensorium, meningitis, very, very rare. I have not seen following spinal any meningitis, but CSF analysis also have to be kept in mind. And of course, transthoracic echo and abdominal ultrasound to overall complete the assessment. But importantly, other entity which is commonly missed is jaundice complicating pregnancy. So when you have a patient with jaundice complicating pregnancy, we know the commonest HELP and AFLP and preeclampsia related, we are very well versed. But importantly, the treatable causes are very important, because we know that if it is AFLP, the treatment is immediate termination of pregnancy. But non-pregnant causes are very important, like simple like enteral fever, dengue or malaria or leptospirosis or scrub typhus, especially in Vellore and the things, scrub typhus is very common. Leptospira, especially following monsoon, is common. And these are the treatable causes which can be treated with macrolide or penicillins, can be targeted. So have a low threshold. If the patient doesn't fit into HELP or AFLP, you need to rule out other causes. And sometimes you need to do entire jaundice panel to prognosticate the outcome, because especially we know that hepatitis E and other things can have a very fulminant course post-delivery, so you need to keep in mind. So basically the point which I want to convey is, when a mother approaches with any febrile illness, targeted approach is very important, depending on what are the modified early warning symptoms and signs he is having, and based on that you target appropriate illness so that you can give a appropriate treatment. Thank you very much.
Thank you very much, Dr. Sunil Pandey, for the very highly informative talk. The messages that I got is this high index of suspicion should be there,
absolutely.
Immediate source control, hit fast, hit hard, then clinical assessment supersedes labs.
Diagnostic stewardship. Don't do unnecessary investigation. When the mother is workup, do extensive.
Yes. Then, and also in the previous talk also, and in this talk, you repeatedly said POCUS, point of care ultrasound. So these are the messages that I got, and highly informative. Thank you very much.
Thank you.
Any queries from the audience?
Thank you, sir, for that elaborate and extensive talk. I request you to kindly stay back on the stage for a group photo. I request Justice sir also to kindly join them, the chairpersons, for a photo. Before we go for a coffee break, there are two announcements to be made.